Good morning. Welcome to the next session of the Healthcare and Life Sciences track in this final day of TC17. I'm Andy Day. I'm the Senior Director for Healthcare and Life Sciences at Tableau, as one of the leaders who helped establish the Healthcare and Life Sciences business unit. I'm responsible for growing the business worldwide. So it is my honor and pleasure to introduce our next set of speakers who come all the way from Alberta. Dr. Hussain Usman is the Exec Director of Public Health Surveillance and Infrastructure at Alberta Health Services. He wears a lot of hats. He's trained as a medical doctor, has a master's in epidemiology, has a PhD in public health, and also has a fellowship in public health informatics from the CDC. With 15 years of public health experience, he's also a thought leader and has published numerous articles in public health surveillance and data visualization. Speaking with him is Kyle Kemp, who's the lead of patient experience measurement, analytics, and reporting, and primary data support at the Alberta Health Services. In this role, he leads teams that deploy Tableau analytics for Alberta Health Services. He has over 15 years of experience in this area and is also currently pursuing his PhD in health services research at the University of Calgary. Please welcome Dr. Hussain Usman and Kyle Kemp. Thank you so much.
There we are. Can everyone hear me? Those of you in the back? Excellent. Thank you very much, Andy, for that warm welcome, and greetings to all of you from Canada. Thank you for joining us at our session today, and we're going to give you a glimpse of some of the stuff that we're doing here at Alberta Health Services, so we're very pleased to be here. So our agenda for this morning, I'm just going to give you a brief introduction of our organization and what I like to call Canada 101, for those of you who've maybe heard a few myths. We're going to talk about some of the analytics infrastructure at Alberta Health Services, and then we're going to show two applied examples of how we use Tableau, two of the many ways that we use Tableau, rather. The first one, I'll be talking about patient experience and how we link that data up with our outcomes data, so things like hospital readmissions and emergency department stays. And then Hussain will be speaking to how he uses Tableau with his team for public health surveillance, and then we'll have some time at the conclusion for some Q&A. So Alberta Health Services was formed in May of 2008, and it was an amalgamation of 9 regional health authorities across our province and 3 agencies. So we are one large, fully integrated healthcare system for the entire province of Alberta. So we cover the entire province and its 4.2 million residents. With respect to the size of our organization, we employ 108,000 people, including 9,700 physicians, and we have almost 16,000 volunteers. Just to give you an idea of the scope, Alberta Health Services employs more people in the province of Alberta than McDonald's does across all of Canada, so a very huge organization. Like I mentioned, we serve all of our 4.2 million residents at all touch points across the spectrum, and we have over 650 facilities across the province. Clinically, just to give you an idea of some of the numbers that we deal with on a year-to-year basis, these are 2015-16 fiscal year numbers, and you can see just the immense volume that we treat at all touch points. So just a few highlights: 2.8 million total hospital bed days, 2.1 million emergency department visits, over 500,000 ambulance trips, and we also cover things that you wouldn't imagine a healthcare system may do. Things like food safety inspections that you can see there. We also do seasonal influenza immunizations, and you can see that there are over 55,000 babies born across our province every year in our facilities. So here's the Canada 101 section with bated breath. So those of you may be aware, that is our flag. We celebrated our 150th anniversary as a country. I know, it's not that old. To dispel a few myths, in fact, maybe I'll be fueling them. Yes, we do love maple syrup. You can see a nice bottle of it right there. One of our chief exports is the Cirque du Soleil, so thank you for attending our shows in Las Vegas. There was actually a viz in the data village I saw that had the six different locations across Las Vegas, so I thought that was pretty cool. Of course, we all play hockey, every single one of us. And that little picture in the bottom left-hand corner is actually a picture of my rec league hockey team. So I'm not going to bore you with our details. It's actually kind of sad and depressing, so I'm just going to move on. In the bottom right-hand corner, leading up to Canada's 150th anniversary last year, the CBC, the Canadian Broadcasting Corporation, put together a contest where people could vote online, phone in, you name it, and basically they selected who they thought was the greatest Canadian. So the usual suspects, of course, came up, people like Wayne Gretzky, Celine Dion, we all know her. You know, I was surprised even Biebs factored in a way, so. But this is the gentleman who actually ended up winning. And for those of you who are not aware, that's Tommy Douglas. And what he did, he was the Premier of Saskatchewan, province to the east of us, up in Canada. And he was the first provincial government to institute universal healthcare coverage. So basically, all of your hospital services were paid for. You know, there was no user fee, you didn't have to get a bill at the end. Of course, there is a way that they get money for that, and that comes through taxation. That we've expanded, of course, the program nationally since then, since 1971, and basically across the health spectrum, we've done that. So in terms of health spending in Canada, on the left is a graphic from the Canadian Institute for Health Information produced last year. And we spend about $228 billion each year on healthcare. And that actually represents 2.7% increase from the previous year. And it represents about $6,300 for every man, woman, and child in Canada. It represents 11% of our total GDP. And in terms of provincial spending, Alberta is the second highest provincially. We spend just under $7,000 per person. And on the right is just a breakdown of the 2015-16 fiscal year budget of the Alberta government. These are the expenses. And you can see in that top right corner, health represents the largest chunk of it, about 40% of the government expenditures going towards health. The operating budget of Alberta Health Services is approximately $17 billion, so quite a large chunk of change. And this is actually the same case in many provinces across Canada, usually anywhere between 30 and 50% of total expenses going towards healthcare. So Hussein and I come at it with a little bit of a different angle. We're basically tasked in our organization, of course, to do more with less or more with what we have. You know, it's not a question of opening up greater expenses, et cetera. So that's kind of our angle with that. So you may be asking why Tableau? So obviously our fully integrated provincial healthcare organization had a need to harness the potential of our data. We have very vast data sources, which I'll touch on in a moment, and we basically needed a way to harness the ability. And we've talked about cost as a key consideration already. Analyst time, like most of you in the room, that's obviously an issue. The timeliness of reporting as well. We don't want old data going out. We want it to be as real time as possible. And then geography. Geography is a huge, huge issue in Alberta. The size of Alberta, we're about 1.5 times the size of the state of California, with only 4.2 million residents, of course. 2.4 million of which live in our two major metropolitan cities, Edmonton, which is where Hussein comes from, and Calgary, which is where I'm from. So with respect to the analytics infrastructure, this just highlights some of the data assets that we have on a provincial basis. So the usual suspects, inpatient visits, emergency department visits, our practitioner claims data, you know, prescription data, labs, DI, imaging, you name it. We also have public health data, of course, and then the experience surveys that I'll be talking about in a bit. So many of you probably can identify with this process in your own organization. So typically what would happen is a clinical team, quality improvement team, you name it, would come to an analyst such as myself. They would put in a request. I would go out and meet with them over the telephone, in person, you name it. And then I'd go off and I'd produce many, many reports pre-Tableau. And then, of course, I'd feel really good about myself, and then that eventual facepalm would come up eventually, because either the report was great, now we want it stratified by gender, could you do it for this hospital only, the 65 years and older cohort, et cetera, or the ask wasn't very specific. You know, they asked for all the data on a given subject, and they really wanted it refined down, which obviously is a challenge that probably many of you identify with. Fast forward to after Tableau implementation, so that meeting still takes place, of course, and then we'll push as much data as we can into Tableau in the desktop server and public environments, wherever necessary. That, of course, goes out to all of our folks across our organization via customized dashboards. And the geography piece is huge, of course. So it's not a question of, you know, walking down the hallway of a hospital and talking to the CEO or the unit manager or whatever. We do a lot of virtual work. And just to give you an idea of the scope, Hussein and I had actually never met until Monday in person. We'd always talked via Skype or whatnot. So this is just gives you an idea of the scope of our organization. With respect to the evolution and uptake at AHS, you can see back in 2010 in that bottom left-hand corner, our first Tableau desktop license was purchased. Jason, actually, a colleague of ours right here in the front row, downloaded the 30-day trial, enjoyed it, put together a business case, put it through on his credit card, got reimbursed, and it's just grown exponentially since then. You can see the timeline across the bottom, and I'll highlight a few touch points. In 2013, we achieved 100 desktop licenses. In 2015, we had 1,000 workbooks in production and 5,900 dashboards. And in 2017, I'll show you in a moment as well, Accreditation Canada recognized Tableau as one of the great strengths at Alberta Health Services, and we are in fact a leader in this type of technology across Canada. On the right-hand side is just a snapshot of some of the analytics around the use of Tableau in AHS. So you could see this was back in early September, just over 12,000 dashboards in production. We had 420 analysts with Tableau, 389 desktop licenses in that second row. And you could see the number of views in the past week, over 169,000. So quite a huge evolution in terms of how we deploy our data in Tableau. This is just a screenshot of the home page once someone logs in to our Tableau page on our intranet, our internal firewall. So basically, these are the pages that greet you. There's an executive portal, which I'll highlight. Those feature our 17 publicly reported performance measures. There's some statistics in and around server performance and usage. That all comes from Jason and his team. There's also some resources for people looking to learn or looking to ask questions. And there's also the Accreditation Canada banner on the right-hand side, which I just mentioned. So some of the activities, we have a Tableau support team within our organization. They organize Tableau training sessions. These are the in-person classroom sessions. And we have beginner, intermediate, and advanced levels that occur every few months across the province. There are weekly Tableau doctor sessions. These are virtual Skype sessions where people can bring questions forward, just similar to the sessions that are here at the conference. That team also maintains the Tableau server. They address queries from end users, like a help desk style via email. Something's not loading, I'm having trouble logging in, you name it. They also monitor all of our server traffic and make sure we're all playing by the rules in terms of privacy guidelines and legislation. So now I'll highlight one example. This is how I use the patient experience data and link it with outcomes in Tableau. So for those of you who are in the healthcare system, I do apologize, but I do feel it's important to reiterate this. So why is it important to document patient experience? Well, just like any other industry, hotel industry, here at the Tableau conference via the conference app, you want to obtain direct feedback from your clients, or in our case, patients. That feedback, of course, can be used to improve care, especially within the context of patient-centered care. So patient-centered care basically meaning that instead of having a one-size-fits-all model for your healthcare system, you're starting to incorporate some of the patient's values, et cetera, beliefs into the care. And then, of course, where we really start to punch above our weight a little bit is we can actually compare the patient experience data with other outcomes, as I spoke of earlier. And that's all done within the context of the Institute for Healthcare Improvement's Triple Aim framework. So for those of you who are not familiar, the three main elements are to improve your patient experience, improve population health, all while decreasing per capita costs. So it's a win-win for the organization and patients, hopefully. So the way that we do the survey in Alberta Health Services, we use a modified version of the Canadian Patient Experience Survey of Inpatient Care Instrument. That actually has been adapted from the standard HCAHPS survey in the United States. It features all of the HCAHPS core questions that are used here. We also have some items that were introduced for Canadian content, definitely things around access to care. There's some additional questions in and around transitions of care as well. And then we also have some items that are AHS specific as well, and those pertain primarily to patient complaints and questions around pharmacy care. So it's a telephone survey that we administer across 93 hospitals, and we've been doing so provincially since 2011. We capture 10% of eligible discharges from each hospital, and we get about 25,000 plus surveys per year, so quite a large volume of data coming in. And the way that we run this process is we get a clinical extract from our information systems every 2 weeks of all of our discharges. We run our exclusion script to make sure we're only capturing patients who are eligible for the survey. We then import that into our computer-assisted telephone interview software, our CADI program. And then we have a team of health research interviewers out of my offices in Calgary. We have about 50 or 60 of them who call around the province to get these surveys done. And they phone 9 to 9 Monday to Friday and 10 to 4 on Saturdays, so at varying times. Once all those surveys are captured into the CADI program, I then extract that. I use the data reshape tool in Excel, the Tableau add-in. For those of you who are familiar with Steve Wexler's work, this came directly from him. If any of you are working with Tableau and survey data, I encourage you to check out his webpage, datarevelations.com. It's been instrumental for my learning, so really, really fabulous stuff that he produces. And then once I reshape the data in Excel, I'll throw it into SAS, do a little bit of further data preparation and cleaning, and then I generate a Tableau extract, and we'll talk about that right now. So I do have to say, these are not mind-blowing visualizations, very simple, but it captures it, and really targeting the end users, not trying to bog them down in detail. So there's lots of filters down the right-hand side, so we're really just looking at a cross-sectional point-in-time view of how a particular hospital is doing. And the end user can select a question theme on the right-hand side. Once they do so, all the questions that pertain to that theme will appear. They can select a time period. We have drilled down by fiscal year, semi-annual, and quarterly periods, and you can see the fiscal year is displayed there. The hospital number has been blinded, and then in the cases of larger hospitals in our province, there are 14 of the largest hospitals, you can actually drill down to the discharge unit, so to action a little bit of local level unit-specific data. And you can see all the questions are there. All of the response options are featured, so it's not just your top box measure, like many of you perhaps report. And then you can see a few notes about the data at the bottom and then who to contact if there's any issues. So my phone rings and I know someone's angry with me. So then moving into a longitudinal view, this is where we're capturing the top box. So basically, how are we doing over time is the question that we're answering here. The same filters are featured down the right-hand side that I spoke of. And what we're looking at is the top box percentage for each question on the survey. Users can select out specific questions and do so. This is probably the third or fourth iteration of this page. And one of the newer features is we've added in error bars. So I alluded to getting phone calls from across the province. Quality consultants, unit managers, whatever will call me. And they'll say, oh my God, we've gone from say 83% to 82 quarter to quarter. What's going on, should I panic, etc. So this is where the error bars came from. So there's a little bit of data literacy that has to come into play. So basically, if the change is outside of those error bars, of course, you know that there was a statistically significant change. Otherwise, it's just a little bit of the random error that happens with surveying. So where we really expand this out is we combined all of our survey data with our inpatient records, not only the index visit, but then looking forward up to 90 days post-discharge. And what is featured here is the end user can go and click on a specific question that they're interested in. The one that is shown is pertaining to patient involvement in their care. So basically that question is displayed. For those of you in the back, it's were you involved as much as you wanted to be in decisions about your care and treatment during this hospital stay? Down the y-axis is the percent of readmissions, and each line represents a specific answer to the survey. And the time frame is selected right now is 30 days post-discharge. So you could see that folks who responded never to that question were readmitted at about 9% over the next 30 days. Contrast, patients who responded always, about 5%. So obviously it's only associative, it's only correlative data, it's not causative. But it definitely generates some wider discussions, especially in that context of patient-centered care, involvement of their care. And down the right-hand side, there's some similar filters that we saw before. The only other additional one on this one is by geography, so they can drill down to the specific AHS administrative zones, and there are 5 of them. Looking at a similar visualization, that same question is displayed. Very similar filters down the right-hand side, but what we've added in here is you can drill down by sex, age group, and most responsible diagnosis chapter. So you can actually drill down based on the ICD coding, the International Classification of Diseases, and that's the most responsible diagnosis. So what we're looking at here is both males and females in the 65+ age cohort, and we're looking at the most responsible diagnosis chapter J, which is diseases of the respiratory system. In terms of looking at unplanned readmissions, the low-hanging fruit right now for probably many of you in this room as well as in Canada, COPD and heart failure. Those are the two big ones in Canada. The Canadian Institute for Health Information put out a publication last year showing that across Canada, 1 in 5 patients who are discharged with COPD are readmitted within 30 days across Canada. So that's huge. So we're looking to put a dent in that, of course, and this is the type of data that helps to animate that a bit more. So with respect to the impact of these dashboards, there's presently over 2,600 in Alberta Health Services, workbooks rather. This patient experience one is the 8th most viewed, so the uptake has been huge. There are people looking at this all over the province. Of course, it's under the guise of continuous quality improvement. What we're trying to encourage is an organic type patient experience, quote, learning lab, where we encourage some of these organic analytic projects. We don't want to be doing ad hoc reports. We want to get away from that. We want to push it down to the end users. We want the end users to pull their own data, look at it, run with it, massage it, and hopefully improve upon it. I've alluded to this, but it encourages lots of flexibility, so we're moving away from that top-down approach to local action, where someone on a specific unit in a small rural hospital can pull their data and run with it. And then some hospitals have even started whiteboarding. So what they've done is they've had public displays of their HCAHPS patient experience results right on boards in the units. So their staff, the public, patients, family, friends, etc., they can see that and they can see where they are. They can see the strengths of the particular unit. They can see the weaknesses of the particular unit and how the unit is working to remedy that. So it's been very impactful for us. So now I'll transition over to Hussein and he'll share some of his work in public health surveillance.
So everything is falling apart. Now? All right, okay. So as Andy was providing my introduction, I was working for the Centers for Disease Control and Prevention in Atlanta. And 6 years ago, when I and my family, we decided to move to Canada, they did a farewell party for me. And I've worked there for 5 years, so I had a lot of friends and all. And guess what they gave me as a gift because I was moving to Canada? So it was a book, and the title was Hockey for Dummies. So they said, if you want to survive in Canada, you should be able to talk about hockey. And particularly for my first year in Canada, I was working for McGill University in Montreal. And they also told me that actually the hockey's rules and everything was invented in the McGill University. So that was really interesting. Now, I'm going to start my presentation with this slide, and this is my way of acknowledging my team. We have a very, very strongly trained, highly skilled, and very well synchronized team, and that is able to produce what we are producing. And of course, what I'm speaking about today is the work of that entire team. So you have seen one example from the acute care side. I'm from the public health side. Usually public health are treated as the stepchild. But I can tell you that in the world of data visualization, we have a good competition with acute care within the organization. This is a classical or traditional public health surveillance definition. And I have highlighted a few keywords in there. And it's an ongoing systematic collection, analysis, interpretation of data. So the ongoing part is very, very important. Like any other surveillance, it is happening all the time. And then comes the dissemination part, where we disseminate that information to the users so that they can use that information for their decision making. So we call this as a surveillance cycle. So every component of that surveillance cycle is extremely important. So this is a snapshot of a traditional, I'm not expecting you to read through the numbers, but this is just a snapshot again, from CDC. I was in the Division of HIV and AIDS Prevention. You can see a very data-rich table. Here's another snapshot of one of our reports that we used to do in Alberta Health Services on influenza. So the surveillance teams or surveillance departments are known for the quality of their surveillance reports. So traditionally, our surveillance reports are a bunch of tables and figures and narrative and definitions and all put together in the form of reports, and then putting them on the website or sending it to people, and then expecting that they will read those reports and do the action part. Now, this is the famous Jon Snow. And while I was preparing for this presentation, being a public health person, we have our own Jon Snow. There's a following. There's really a cult-like following for this Jon Snow. Seriously, he's like a hero in the world of public health. And this actually, the idea came from one of my colleagues, and I was sharing my slides with him and said, hey, provide me some feedback. And he said, when you will talk about Jon Snow, people will know more about this guy. So you should acknowledge that. So I'm doing it. So this Jon Snow that I'm a big fan of, he lived in the mid-19th century. And for those people who are in the world of health and public health, would know that he was responsible for this famous outbreak investigation for cholera. And that famous hand pump removal, he did one intervention because he figured out that the outbreak was coming from that hand pump where people were drinking water. So he removed the handle of the hand pump, and the outbreak finished. But my point 5 years ago when I joined AHS and I was in that role, I wanted to start a conversation with my team. And these are the snapshots that I took from his report that he did more than 150 years ago. Again, nice tables, some maps and all. And this is the question that I asked my team. And I asked them, what has changed for surveillance reporting in over 150 years? Jon Snow was doing those reports, and we are today doing surveillance reports, and they look very similar. Again, a bunch of tables and figures and narrative, and put it all together, and you expect the action is going to happen. So the limitations of our traditional surveillance reporting is that there is so much manual work that we do that by the time we produce information, it is delayed. People who need that information to do action, the reports are older, they don't have recent data, and usually it's of not much use for them. And the second important piece is that creating information is not sufficient. We all understand that unless we have the ability to find the information that we need to inform our decision making, it is usually of not much use. Now, I know that in this conference, there's a lot of data people and techie people. If we look at the model that we have for Google, it's a very simple model. What Google does is that it connects us to the information. It helps us find the information when we need it. So nobody imagined 10, 15 years ago that Google is going to be among the world's most valuable companies by doing this one simple thing. But they were able to understand that in future, we will have so much information that it will be very hard for people to find information. So then in the team, we decided that, all right, we're going to change things. We're going to create our information products, and we're going to make that available to our users with just one click. And we are going to provide them the information that is very recent, most up-to-date information. And the third thing was that it should also provide some users some interactive experience to them. Now, here I want to say one thing, that the concept of interactive dashboards is not new. For a long time in public health and other areas, we have been working with some IT contractors to develop data-intensive visualizations. But we had some challenges. Cost was one big problem. People from the business side and communicating with our IT colleagues has always been a challenge because we speak different languages. So helping them understand our requirements has been a challenge. Time is very, very important. For example, if we have an outbreak in the province, E. coli outbreak or measles outbreak or something else, we need to put together an information product very, very quickly. So we don't have the time to put a contract in place and hire somebody to do those things and all that. And then the last one, the version control is extremely important, because what we produce as our information products, as dashboards and all those things, they are never finished. We keep improving them based on the feedback that we receive from our users, so that's why having a version control is extremely important. So then for us, the thing is that, okay, what is the game changer? The game changer for us is Tableau, because Tableau allowed us to build an in-house analytics infrastructure. And for an organization with 108,000 employees and the annual budget of like so much and all that, having an in-house infrastructure helps us overcome all the 4 challenges that I showed you in my previous slide. And that I consider that as a game changer. So again, a lot of people think that the dashboard is the game changer. I say no. Having the capability to produce that and overcome all those 4 challenges that we had is the game changer for us. So what we do is that now we produce a lot of dashboards in my area. Again, this is not meant to be read. So the whole idea is, because I've been attending many talks in the conference, and some of the things that we are already doing are really the good tools and tips that they were telling us. So what we do is that we understood very early that when you have a lot of products, people cannot handle like 30, 40, 50 links to find the dashboards. So what we do is every dashboard we produce, this is our landing page, and we provide a link over there for our users so that they're dealing with one link. They're not dealing with 10, 20, 30, 40 links. Over here, there are mainly 2 types of dashboards we have. One type is internal AHS dashboards that public, they don't have access to. And within the internal dashboards, we have dashboards that are open to all 108,000 employees of AHS, and there are some that are restricted. For example, if there's a dashboard on sexually transmitted infections or opioids crisis that we're dealing with, the fentanyl crisis in Alberta, those are restricted ones. The second major type of dashboards is the ones that we are producing for the general public, for the communities and all that. And those are published on the Tableau public server, and those are open to everybody. So what it has done for us is that, as I was telling you, that surveillance people produce a lot of reports. And what Tableau has done for us is that it has simplified the things for us, as well as for the users. So this picture actually tells a lot how the user is now able to see a lot of reports in an interactive format rather than going through all those paper-based reports that we used to do previously. Now, here, I also want to share with you a little bit around our analytics model. One of the reasons that we have been very successful using Tableau is that we are using Tableau in combination with SAS. In public health, we deal with many, many data sources. So for one dashboard, for example, a respiratory virus surveillance dashboard, which includes influenza, we are dealing with around 9 types of different data sources. And then those data sources are, they come in different forms. Like one data source, you are pulling data directly from the server. Another one, lab is sending you a file. The third data source is that you log into a system and download a file and all that. So we wanted, so we are using SAS for pulling all those incoming data in one environment. And that's where all the data management, analysis, and the QA, the majority of that happens in that SAS environment. And now listening to what they shared with us in Maestro, and then there are some other solutions as well, we are going to be gradually moving some of those activities towards the Tableau side. But right now, SAS is our backbone. And from there, we then create these summary data sets and post them on the Oracle server, and then you create the dashboard, provide permissions, and people are able to visualize it. Now, what SAS does for us is that, as I was telling you, surveillance is ongoing. We have real-time dashboards. We have near real-time daily, weekly, quarterly, yearly updates that are happening. So SAS, once the code is written and data access is sorted out, we put the SAS codes on an automatic run so that it is running overnight. You come in the morning, the dashboard is updated. So that's very, very important for us because of the nature of work that we are doing. So now, in a few minutes, I'm going to share a few examples of the dashboards with you. I have chosen a few snapshots from our internal dashboard, and then one that is publicly available. So I know that opioids or this fentanyl crisis is a #1 public health problem in North America at this point. You were giving a presentation yesterday, and you were telling the audience that if you compare it with the number of deaths happening because of the collisions or any other measure you do, we are experiencing a massive public health crisis in North America. So as a surveillance department, we have developed an opioid surveillance dashboard. And it has a lot of information in there, as I was sharing with you, that it brings in information from all sorts of data sources. So for example, we have syndromic surveillance data where when people present in the emergency department, we get a real-time feed. We bring that in. We also have a system in Alberta, we call it HealthLink calls. So if somebody calls the system, then we get real-time data from there as well. Then we also have the ICD-10 coded emergency department data that is updated monthly. So we pull that from our data warehouse. Then we also pull the hospitalizations, physician visits, emergency medical, EMS, the emergency medical services data is coming to us as well. So in surveillance, it's all about completing a full story of what is happening in the province about a particular topic. So you cannot tell the story unless you bring in all the information that you have access to and then present it for our users for their decision making. So this is a snapshot of that dashboard again, and we also have the deaths data and all that. Now, our internal dashboards, as you would see, they are very data-intensive dashboards. They are providing a lot of information to a select group of very technical people so that they know where we are going, are we seeing any impact of our interventions and all that. I'll just highlight one thing over here, that this graph, the line chart that you're seeing over here, starting from 2013 till like 2017, is telling us the number of opioid overdose emergency department visits every month. So you can see that it's going up, up, and up. This problem is not getting better. And I know that it is the same in many parts of North America. So at the top, you will see that there are, our dashboards are, the internal ones are very, very big dashboards. So then, after the summary tab, you have several tabs, and each tab is then providing you details about a specific data source. So we have a dedicated tab for the emergency department data. We have a a dedicated tab for the inpatient hospitalizations, and similarly emergency medical services and all that. Now, for surveillance people, all the time, one question that is asked from us is that, are we producing actionable surveillance information or not? Because it's all about action. Are people able to make any actions or take any actions based on the data that we provide them? And that is always in our mind, because we are producing a lot of information, and not all information is used for making the decisions. So this is something, is like a quality check for us to ask us all the time, is this actionable intelligence? Is this actionable data? So I will share with you one example of that. So when a call comes to EMS for an overdose of opioid, so what happens is that patient is having difficulty breathing, and gradually the breathing stops. And when EMS responds to the location, they provide something called naloxone or Narcan. And this is an antidote to the opioids, which helps you reverse the patient, and the patient starts breathing again, and you prevent a death. One problem that we are facing in Alberta and elsewhere is that there's a higher potency of opioids that are coming in the market. So for example, we have morphine. Fentanyl is 100 times more potent than morphine, and carfentanil is 100 times more potent than fentanyl. Carfentanil is used to sedate elephants, and this is now coming in street drugs. So one important piece of actionable intelligence for us is to monitor the dosage of Narcan or naloxone that EMS people provide to the patient, which helps us understand that maybe a higher potency fentanyl is making its way into the streets and all that. So we get that data, and I'm just giving you one example of on the dashboard, we can actually select based on the dosage provided to the patient. So in this case, I have selected, show me the location of all those cases where more than 2 milligrams of Narcan or naloxone was provided to the patient. And that is very actionable information that we then provide to our medical officers, and they work with the community organizations, and they can take action on that piece. So it's very actionable information, and it's easy for us because we are doing it in Tableau, because it helps us do all those things that we can do. All right, now the second example I'm sharing with you is something that is created for the community. Now you will see that the layout of this dashboard is completely different than what I was showing you as our internal dashboard. So this dashboard has been created. These are community profiles. We divide Alberta into 132 local geographic areas, or call them as communities. And we are providing communities tons of information about their community for a lot of reasons. There are some work that happens in the communities, some research, some other interventions and all that. So there's a strong rationale for providing that information. Now, luckily, in my area, in my department, I also have a small creative services team. And you can, some of these icons that you're seeing over here, we created them ourselves based on the needs of our layout. So in this snapshot, what you're seeing at the top is that there are several tabs in the dashboard. So it starts with the home page, then we have risk factors for chronic diseases like smoking, alcohol use, and all that. There's a tab for that. Then there's cancer screening and immunization tabs that we are seeing, so that the communities can see how their rates of cancer screening and cancer-related immunization, for example, for hepatitis B and HPV. And then there are a couple of advanced user pages that are meant for, there are some people who want to play more with the data, but that's not meant for the general population. So when you land on this page, you will see that it provides you information at Alberta level. So again, 4.2 million population, and all these icons, when you hover over them, it will provide you the label for that. So the percentage of population above 65, the percentage of indigenous population, annual family income and all those things. On the right-hand side, similarly, you have some distribution of income, education, housing, family composition, and all that. So we take a very good, we make very good use of tooltips because it allows you to create simple visualizations, and then you pack information in the tooltips so that your visualizations are nice and crisp. What it does is that once you look at information at the Alberta level, up here, if you enter your postal code or zip code like in US, or you can find your community from the map and you click that and it takes you to your community. So for example, this is the community where I live. It's called Twin Brooks, population of around 75,000. And you can see that, for example, I'm going to compare a couple of indicators for that community as compared to Alberta. So you can see, if you look at that percentage of population in that community with more than 100,000 yearly income is 45%. And that line over here is telling you where Alberta is. So it's a high income community. Similarly, this bar is giving us that 58% of the population living in that community has university, diploma, or degree, really highly educated community and all that. Again, the purpose was to, at a glance, you can see where my community stands as compared to Alberta averages. Am I doing better as a community or worse and all that? So I'm going to go through a few more snapshots, and then we're going to have 10 minutes at the end as a Q&A. So then I'm at the risk factors tab. Again, the risk factors tab starts with the risk factors information at Alberta level. And one innovation that we were able to do in Tableau is that the icons that you're seeing over here, for example, binge drinking and use of vegetables, overweight, and all that, you can see that these icons have a fill in that, right? So that fill relates to that percentage value. And that is a little trick we did, that at the front we have an icon that is transparent, and behind is a bar chart which moves up and down, and that gives you that illusion of a fill created in the icon. And we hope that in future, Tableau may have these things built in, and it will be much easier for the users to do that. Now, and then we make a good use of it. So for example, now I'm looking at information for a particular community, which is a West Log community. And then at the bottom, you will see, so the fill of the icons will change. You hover over it, you will see the percentages and all that. And then the color of that is changing as well. So if you're doing better than the provincial average, your color is blue. Or if you are at close to provincial average or worse than provincial average. And for some indicators, we don't have data, so it says not available. So when the users, they're using that, they can see that change happening, and they hover over it, and they see more information. This is another visualization we created, again, inspired by one of the whizzes on Tableau Public. Now, for these 8 risk factors for a particular community, in this case, West Log, we look at each risk factor and produce a rank of it. So out of 132 community on smoking, where do I rank from 1 to 132? The higher I rank, the closer I will be towards the center. And the worse I am, far I will be from the center. So I will then show you a tooltip that will help you understand. So again, taking good use of tooltip is very important. So for example, now for West Log community, I'm hovering over the current smoker, the prevalence of current smoking. So here is what we are doing. We are providing the question that was in the survey, how was it asked, some context, why is smoking important, because this is for general population. And then below it tells you that this community ranks 30 out of 132 communities. And then below that, you are seeing the prevalence of smoking for West Log as compared to the zone it belongs to. There are 5 zones in Alberta, and then Alberta average. And the last line tells you what was the source of the data. So again, all that information you can nicely pack in the tooltips and that helps the users to find the context. So when you look at this diagram, it works really nicely. You know, when I see it for Twin Brooks, where I live, all the dots are very close to the center, very highly ranked risk factors. And then if you go to some of the rural communities, they're far away from the target. And it helps you understand at a glance for 8 risk factors where my community is. So far, I've been showing you like, you know, a lot of risk factors for one community at a time. Now, this visualization helps you look at one risk factor at a time across all 132 communities. So in this case, for example, I have selected binge drinking over here, and you can see each bar is a community, and the vertical line is the Alberta average. So some communities are doing better than Alberta average, some communities are doing worse than Alberta average. Now, the other thing that I want to highlight, and it was, of course, a big thing yesterday in the Iron Whiz competition, looking at map, like any other map, we have highly populated urban centers that don't show up on a map, right? Calgary and Edmonton. So we created this different visualization where each symbol that you see is one community. It is taking equal space. And also, there are different shapes because we have 5 zones. So each shape represents one zone. And again, you know, when you hover over it, it will tell you more details. But because this is a snapshot, I cannot show you. So again, you know, there are communities with, let's say, very high binge drinking, but they're small on the map. You cannot see them. But you can switch between the actual map and this sort of like a abstract map, we are calling it. It's very similar to the hexagon map yesterday for those who attended the Iron Whiz yesterday. And then there are some advanced user page where you can look at a lot of factors for all 132 communities and see where the communities are. The vertical line, again, is telling you the provincial average and all that. Okay, so I'm gonna not take much because I've talked to most of that so that we have good 7 to 8 minutes for the Q&A. So the benefits, what I can tell you is that we are almost 10 times more productive than we were before Tableau. And even you cannot compare a product done in Tableau versus a paper-based report. I mean, there's not even a comparison. So productivity has gone up. We have a very short turnaround time, and we have full version control on what we produce. For outbreak situations, we can put together a dashboard in a day and start disseminating the information and update it every day or many times in a day. It is definitely saving us money, and it allows us to provide access to dashboards to our all 110,000, 8,000 employees. There's a high quality user experience. We get a lot of feedback. And then, of course, it is resulting in improved decision support and program planning. And as future directions, of course, we want to incorporate more advanced analytics in our products. And we also want to facilitate the use of information. So we are now forming a knowledge translation support team that will facilitate the users to make use of the information products. I think it can be utilized more. And then strengthen the AHS analytics community of practice. And now, before I finish, I just want to acknowledge one person. His name is Jason Scarlett. Because I'm an epidemiologist, and I say that he has spread the virus of Tableau in our organization. So thank you so much, Jason, for that. I'm a big fan of him. So thank you. Okay, sure.
Okay, we have time for a few questions. Any questions up here?
This is a great talk. Thank you. I just wonder, like, why? Can you explain, like, why you move on to use the SAS as the core to managing your data between the SQL and the Tableau. And alternatively, I think that most of people try to connect the SQL to the Tableau directly. So I mean, either way is fine, but this is my first question, why make you to move on this way? And secondly, can you describe a little bit detail about how you operate the SAS to be like automatic update data like every day? Thank you.
Right. So when we talk about these things, there is a whole topic of change management. So when you're trying to make a change in an organization, you try to work with the ingredients that you have available and the talent and all that. So looking at our data sources is not, SQL is not only or the sole source. We get data in so many different forms that we needed a central sort of like a backbone to bring everything in so that data can talk to each other and all that. The second reason is that I've been a SAS user for over 15 years. It was a little easier for me to develop that and train people and all. So I was the ingredient for that. The other question was the automation, right? So once you write the SAS code, you can actually put it on an auto run. So on Windows, you can do it on Windows or on Linux environment as well. And it just wakes up in the night, 2 a.m., and it pulls all sorts of data, does the analysis, and updates the dashboard. Thank you.
Hi, my name is Stephen Rizzo. I'm with Prescaney. I'm particularly interested in what you're doing with your patient experience data in Tableau. I guess my question is twofold. First of all, what proportion of your patient experience reporting are you doing in Tableau? And then secondly, what proportion of it is more sort of data exploration, which is kind of what you were showing up there, relating it to readmissions measures, and what proportion is more scorecards or more static reports?
Absolutely. Great, thank you. Yeah, most of the reports will now go out in Tableau. We have migrated to primarily Tableau use. With that said, some of our executives still do prefer those paper reports. So on a quarterly basis, they will get the paper in hand from colleagues of mine on my team. And with respect to the exploratory analysis, actually, in his intro, Andy had mentioned that I'm pursuing my PhD, and that's actually where my topic came from. I realized there was a huge dearth of information in Canada, and we've actually become the leader across Canada in terms of patient experience and linking it with other outcomes. It's been very fruitful. We've been able to publish 6 papers out of it in the past 3 years. I've presented at probably about 20 different conferences, which has been just fabulous. We've even linked up with some of the colleagues who you probably know from RAND, people like Mark Elliott, Ron Hayes, et cetera. So it's been very fruitful. But yeah, largely exploratory, and it's actually really interesting and insightful to see, you know, when we present the data in Tableau, these types of exploratory data, you know, just the reactions that it gets. I'm on a lot of committees, patient and family-centered care, patient experience committees across Alberta Health Services, and on those committees we actually even have patient and family representatives, so members of the general public who sit at the table and they help with decision making and feedback and et cetera. And it's very, very insightful to see, very, very wonderful. So thank you.
One last question.
Okay, it's very useful to have a microphone because I'm starting to lose my voice. Chris Von Simpson at Eckerson Group. I'm really interested in helping BI and analytics teams get more resources, and so I'm really focused on the benefits. Wow. I'm really focused on the benefits of the work that you do, and you mentioned that you had cost benefits there. I was wondering if you could talk a bit more about that.
Yeah, I can speak a little bit about this. So what we have done is that we have produced a lot in the last few years, and it has demonstrated the capability. The senior management, a lot of times, they have a past experience where they have been sold a concept, but were never delivered. So what we did was that we started producing and showed that this is real, this is just not a concept. I think that was the one biggest thing that helped us get more resources. So with that capability, one thing that is happening is that I have other areas like healthy living and safe, healthy environments and injury people and all that. Now, they all come to us for developing their products, and then when they come to us and I say, you need to provide me an FTE or two, and I'll chip in some, and we'll develop a joint project, and we will do it. And we have been very successful in doing that. So again, I think the key is to demonstrate the capability, and then I think the things that start falling in place automatically. People start seeing the value, and their doubts are gone, and they're more helpful.
Awesome. That's all the time we have for today. Thank you very much for your attendance. Big round of applause for Dr. Usman and Kyle for an excellent presentation.